right, in our last video, we talked about these inhibitory postsynaptic potentials and excitatory postsynaptic potentials. And basically we're talking about a graded potential that occurs on the second neuron. So we have a stimulus that stimulates the presynaptic neuron, generates an action potential, causes the release of some neurotransmitter. Most commonly, what is the most common neurotransmitter released from the presynaptic neuron? Acetylcholine. So that is released depending on the amount of binding on that postsynaptic neuron. We're going to generate either an excitatory postsynaptic potential where it's going to depolarize and lead us closer to an action potential, or it's going to hyperpolarize and take us away from threshold to reach an action potential. So these different types of potentials are graded potentials. So they occur before threshold, and they can add up. So when we say summate means to add up. So if I have 2 EPSPs, so I'll just draw that here. If I have 2 EPSPs and I have 3 IPSPs, what's going to happen to my membrane? Am I going to get closer to threshold or further away from threshold? Further away, because I have more inhibitory, I have more hyperpolarization potentials than I do depolarization potentials. Because remember, EPSPs go in this direction, right? And IPSPs go in this direction. So this is leading us closer to threshold. This is leading us further from threshold. So they add up, and they can cancel each other out. So if I have two excitatory and 2 inhibitory, I could end up with no movement of ions because they simply cancel each other out. Or I shouldn't say no movement of ions, but I have no depolarization or hyperpolarization of the membrane. So we have multiple inputs to postsynaptic neurons, releasing neurotransmitters. Some of those neurotransmitters stimulate and depolarize, some hyperpolarize. And we're going to talk a lot about neurotransmitters today for our lecture. So we're going to get into that topic now. So there is a handout that is posted in Blackboard that is just a simple multiple choice quiz on the most common neurotransmitters we talk about or that you hear about, you know, different drugs and things, what they're acting on. Maybe you don't hear about the neurotransmitter, but you hear about the drugs and the effects. So we're going to apply it to what neurotransmitter those drugs are either promoting or inhibiting. So I'll pull that up here in just a minute. So let's look at, so there's 50 neurotransmitters that have been identified. And we'll talk about how those work. So the first neurotransmitter I want to talk about, if you look in your list, I'll pull it up here. Let's see. Oh, that's not the one I want. Oh, it is the one I want. Okay, so we have these are a list of common neurotransmitters that you see listed A through H as your choices. So when we look at alcohol really, what does it do to the nervous system? Does it stimulate it or depress it? We know it depresses it, right? So much that a person can pass out and stop breathing. It can depress the nervous system that much, and that's, you know, alcohol toxicity, and that's why we never abandon someone who falls asleep drinking if we don't know, you know, how much they've drank over the period of the evening. Like 21st birthdays can be deadly for people because people, you know, maybe they don't drink a lot and it's their 21st birthday, everybody's buying them shots and they're taking in small amounts of high proof alcohol. Can be very dangerous. We had a person on our unit one time that ended up in a deadly heart rhythm as a result of too much alcohol toxicity, and that does happen to people, that it has this impact on the heart that disturbs the electrical conduction pathway, and they end up with a permanent heart arrhythmia from it. And this guy was on our floor, and then he had to go to Madison and get set with a pacemaker because his heart was permanently damaged from his 21st birthday. And he was not much of a drinker, so it was quite a shock to his system. So of these, it's GABA that is the #1 neurotransmitter that is promoted by alcohol. So GABA normally slows down our nervous system, and alcohol promotes the release of GABA and the effects of GABA. So the more we drink, the more we promote the effects of GABA, and the slower the nervous system responds. Cocaine causes an extra release of dopamine. Extra release of dopamine, and that causes kind of hyperactivity, high energy. People use cocaine to just feel really on their game and party all night long and have a lot of energy and confidence. And then what happens is we have a lot of this dopamine around from the effects of cocaine. What happens then is when the cocaine goes away, we have downregulation occurring in the brain, so the brain removes dopamine receptors because there's been so much of this dopamine-like chemical in the system, known as cocaine, that downregulation occurs, and then when they don't have cocaine, they crash hard. Energy is low, depression, and people really start to become dependent on cocaine because of, and that's crack too, right? Crack cocaine. They become dependent on that because the brain chemistry changes. When we say brain chemistry changes, we either release less of these normal neurotransmitters like dopamine because there's so much cocaine floating around, and the receptors on the brain for these neurotransmitters downregulate because there's so much of that chemical around. So there's two things happening: less production of the normal transmitter and fewer receptors for that transmitter because of the drug usage. So people crash hard. Caffeine blocks this inhibitory neurotransmitter binding to receptors, causing stimulatory effects. So caffeine, let me look at, what do you think? Which one did we say is an inhibitory neurotransmitter? We already talked about it. Which one did we already say was the inhibitory one? GABA. Yep. So it inhibits this and makes us feel like we have a little more energy, right? Caffeine is the #1 most commonly abused drug, if you want to call it. It is a drug. It's a chemical, right? It's not produced by our body. And it is readily addicted to, which means the body can quickly adapt to wanting and needing caffeine to feel good. And the good news is after about 2 to 3 days, you can kick the caffeine habit. But those 2 to 3 days are pretty miserable. If anybody's ever tried to kick the caffeine habit, it can be pretty bad, right? Your brain is like slow and bad headache, very tired, yeah. But if you can kick the habit and go to some like healthy metabolic, things in our diet that support energy. A lot of people swear by that. People that have kicked the caffeine habit and gone to clean eating, they say they've had as much energy as when they were eating poorly and taking in a lot of caffeine. So it just takes that switch over, which is difficult to get to, right? And how is that different in some cases of people that are addicted to illegal drugs? They don't want to do that switch over, right, to quitting the drug and maybe going on some medication to help their depression or anxiety or whatever the underlying issue is. Because most people that abuse drugs are self-medicating and using those drugs to overcome depression or anxiety or other mental health problems. And that's really the issue that we see in the jail. A lot of people end up in jail because of having illegal drugs on their person or being involved in activities related to drug use. And then they're detoxing from the drugs. So we give them medicines to help with the detox, and then we have to deal with the underlying mental health problems that are now going to appear and show themselves as they're detoxing. And the detox drugs don't always treat the mental health problem. So we're trying to find that delicate balance with brain chemistry. And when people have been, messing with their brain chemistry for years to try to get that stable and get them functional, is not easy either. So oftentimes they pass drugs around in the jail. It's a real problem. You give somebody some Tylenol or some withdrawal medicines, they tuck it in their cheek and they smile and show you under their tongue that they took the medicine, but actually it's in the far back of their cheek. They spit it out, they keep it in an envelope, and then they share it amongst each other. And it's a real problem, because if you get too much of one medicine built up and then someone takes it, they can OD in the jail, and that's a big problem in prisons and jails across the country, as people are ODing. There was a story of one guy, a jailer. Somebody was coming into the jail and with an unknown powder in an envelope, and as they were opening it up, the powder got on his skin. Bam, he was down like a ton of bricks and had to be Narcan to be brought back. So what was in that powder? Some really powerful medicine that absorbed through the skin. So these drugs can act very quickly on receptors in the nervous system, through the skin, mucous membranes, inhaling, whatever. So caffeine blocks Gaba. All right, morphine, heroin, and methadone mimic this group of neurotransmitters by binding to its receptors. What do you think? Morphine, heroin. I'm trying to find our list here. I want to give you a page reference here also. I can find our page reference. I believe it's in chapter 12. I'll have to look in the back of the book. Because this is these morphine, heroin, and methadone, those are common drugs. Morphine is used in the hospital for pain relief. It's a very powerful pain reliever, and it also helps people cope with the sensation of being short of breath. We give people morphine because it blocks that short of breath anxiety response. And when people are dying or people have really bad respiratory systems, they're dying of lung cancer, for example, and they're not going to be able to breathe, we don't want them to feel uncomfortable through the dying process. So morphine just kind of shuts that response down and doesn't force you to want to take a deep breath. So some people are on morphine for pain control. So they're majorly at risk for stopping of breathing, right? So anybody that's on a morphine or morphine-like medicine has to be on a special device where we measure their exhale and their respiratory rate to make sure they're breathing while they're on this pain medicine. The pain pump, you've seen those where they push the button and they get a little dose going in through their, sometimes it's through an epidural or it's through the IV. What were you saying? Uh-huh.
I've got the Narcan here, and she goes, "You quit breathing."
Oh my goodness. Wow. Well, they should have been watching that a little more closely, I think, because...
I thought that it does.
Right.
But it just builds out.
Maybe you were a little more sensitive to it, yeah, because it blocks you out after a period of time that you shouldn't have it building up so much. But again, you probably had that machine connected to you, right? It's like a oxygen with a little circular disc there, and then it's measuring your breath. So then it alarms. Yeah. You must be what they call a low flyer, which means you just need a little bit of medicine and you're out. Yeah. Okay, so these medicines are called opiates, right? Have you heard of, and that's why opioids are things like oxycodone that we take, Lortab, hydromorphone, Those are things that we take for pain, big pain, like if you have your wisdom teeth pulled out, you break a bone, you get some of these medicines. And then people get addicted to them because they like the relaxed feeling that they get because it causes the brain to release endorphins. So endorphins is the class of neurotransmitters. And that makes us feel kind of happy. It has a numbing effect on the body. So have you heard of runner's high? When people get to like our marathon runners, when they do a long run, they get it depends on the individual. I was doing long running for a while, and I hit runner's high once in my probably 2 years of running long, and it felt awesome. What?
Made it all worth it.
Yeah, right. No, it was right. But some people get it all the time, so it just depends on the individual, and that's how people can get kind of addicted to running because you get to that point, and it is a great feeling. I hit it at mile 9, and you're slogging along, and it's like, oh, your joints are starting to hurt, and you're just like, oh, I'm tired, I'm bored. Then all of a sudden, boom, this runner's high hits, and your pain goes away, and your breathing feels like awesome. You feel like you could take deep breaths, and then pretty soon I was running like fast, like what I would run in like the first mile of a 5K. I was running that at mile 9. Oh my gosh! And then it wore off, and then I was back down to And I even looked at my running app, and that mile 9 was really good compared to before and after. So it's a great thing. Endorphins are wonderful, and we release endorphins when we eat things we enjoy, like chocolate cake. We just feel like, oh, this is so good, and we just enjoy it, right? Endorphins are released with orgasm, particularly with the male orgasm, because male orgasm causes the nervous system to kind of relax and shut down, and that's part of the reproductive response in males. Again, so the buck with the female deer at the watering hole goes away. He does his business, and then he's tired and lethargic and goes away and leaves her alone, because no point. Yeah, and gets shot, right? Yeah. Spoken by a hunter, yes. But the female, she's cranked up and then runs, and finds cover, right? So she isn't exposed for getting shot. Anyway, so morphine, heroin, and methadone are all promoting the feeling of endorphins. So you can see why people go to these things. If they're depressed or anxious or miserable, and they can take a hit of heroin, life is good. Heroin, what does that stand for? What is a heroine? Heroine is like a person that's in charge and can save people, right? Oh, my heroine is here to take me, right? Like superheroes, heroine, have you heard of, I think it's without the E on the end, right? What? Is it? Oh, okay, didn't know that. Female version of a superhero. So anyway, endorphins are what those medicines. So people start out with oxycodone, maybe in innocent, hospital stay, and then they get a refill when they get home, and they keep taking them. The pain is gone. They've healed from the surgery, but they're like, gosh, I'm just going to take that oxy because it really made me feel just relaxed, and then I can just watch a movie and chill out. And then pretty soon they're taking that oxy for the wrong reason. And I can tell you this is happening because I've had this conversation with patients over and over and over again. They're getting ready for discharge. You ask them what their pain is, and it's nothing, and they're walking the halls. But then at bedtime, they want their oxy, and then they're rating their pain at 9. And they were dozing when you came in there. And you wonder, how can your pain be at 9 and you're dozing? And then I was in a conversation one time. I said, well, we had medicines for sleep. If you're looking for medicine for sleep, we have a different medicine we can give you for that. But the oxycodone, we really want to wean you off of. And he's like, why can't you just give me the oxycodone? I'll be honest, I just feel good when I take it. And I'm like, that was definitely the wrong thing to say, because that's not why we give that medicine, is just to make you feel good, right? It's to stop pain. But now we have to be careful. You have a person who's addicted to drugs, they're going to have a really high tolerance to these medicines. But does that mean they deserve to be in pain after they have surgery? Definitely not. They deserve to have their pain treated. It's not our goal as nurses to judge people in the 5 days they're in the hospital, right? Because we need to treat their pain like anybody else, right? But we don't continue to keep the high doses of pain medicines beyond what's typical. Then we're helping support their addiction. And that has happened also. As a nurse, I've had to call the doctor and say, can you take this oxycodone off the MAR? Because nurses are giving it inappropriately. I can see, because sometimes you're busy and you just don't want to deal with it, and you're like, okay, you can have it. Yep, I'll give you 2. Yep. Every 4 hours, I'll give you your 2 oxycodone. No, that's not appropriate. And they will, some people will ask for it if they know you can give it to them. But otherwise, just call the doctor, tell them the situation, let the doctor be the bad guy. Then you can say, oh, I'm sorry, the doctor said that's not appropriate for you anymore. We have Tylenol or ibuprofen I can offer you, or how about a warm blanket? And we'll talk about temperature and massage in a little bit. Marijuana mimics this inhibitory neurotransmitter. So it's an inhibitory neurotransmitter. So how does it make the nervous system feel? Mellow, relaxed, yeah. Now it's not GABA where it makes you totally like sluggish, right? But it's just mellow, relaxed. That's the endocannabinoids. We actually have cannabinoid receptors on our brain cells that normally we release natural neurotransmitters that bind to these receptors to relieve anxiety. Now, if you smoke a bunch of marijuana, you're a wake and bake kind of person. I'm not talking about occasional, that's what it's called. We're not talking about occasional marijuana use, you know, at a party or here and there. And I'm not promoting that either, but I'm just saying that's not what I'm talking about. I'm talking about wake and bake, which means you wake up, you smoke your pot, you got your jag going, you go about your day, it starts to wear off, you go back to your car, you take another hit, you go about your day. You get home from work, you take another hit, do your thing, take another hit, and you go to bed, right? Over time, it is a lie, 100%, with what you see online, that there is no effects of chronic marijuana use on the brain. That is a lie. Talk to anybody who works with chemical dependency, who works with people that do this kind of chronic marijuana use. It does affect brain chemistry, and it can change it permanently. There are people, a good group of people that will, even if they're going to be honest with you, when they stop using marijuana, they have anxiety and insomnia. Because what's going to happen? Down regulation, they're going to pull receptors because you've got this marijuana binding to these endocannabinoids chronically. You're going to produce less of those natural marijuana cannabinoid-like neurotransmitters that help relax and promote rest. And then over time, you can't produce it anymore. So a lot of people that quit their chronic marijuana use have to switch to an anti-anxiety drug for lifelong health and stability. So it's not something like you hear on, you know, Joe's Marijuana is Life page will tell you that there's no effects of that. There definitely is not. Now, do people go into detox and seizures and DTs and all of that when they stop marijuana? No. Do they feel anxious when they stop marijuana? Yes. Yes, they do. And that's what causes people to go back to it over and over and over again, is because it helps them feel relaxed. Now, I was having a conversation a while ago with a student that was talking about marijuana use and how it just killed motivation. And that was the reason that they stopped using, because it just killed motivation, because it makes all the problems in life go away, right? And when you're skipping class, it doesn't bother you that much if you just have a little marijuana and relax and listen to some good music, right? So is that good for us? You know, when we talk about legislation to promote these things, do we want to, as a society, write off on legislation people to use substances that kills motivation and they don't want to go to work and they don't want to go to school and they just flub out? How many people do you know? I'm not going to ask you, but you probably know some people, right, that use a lot of marijuana and are not real effective in their lives, right? And I'm not, again, talking about here and there. I'm talking about chronic marijuana users. It's a way that people cope with a life that's not real fulfilling. And do we want to promote that? Because, you know, it's like anything. Alcohol is legal. Are 21-year-olds the only ones that are using alcohol? Abusing alcohol? Probably most of the abuse is between what, 15 maybe and 21 is where a lot of the crazy stuff happens, right? Not always, it still happens. And so it's the same thing when we legalize something like marijuana and say, go ahead, if it feels good, do it. People are going to be abusing it in the young, and they've done research, and chronic marijuana use in the adolescent years causes permanent brain changes that they can show anatomical changes on MRI scans about chronic marijuana use in adolescence prior to the brain's maturity. So these are things that are factual, they're out there, but nobody wants to talk about it because people don't want to hear that, right? Only the most vocal are the ones that we listen to. Okay, number 6, receptors for this are damaged in those with Parkinson's disease. Do you know? Here's a hint. A medicine we give them is called levodopa. So what are we trying to mimic? Dopamine, yeah, dopamine. So the receptors for dopamine are damaged. So as a result, dopamine helps calm motor output coming from the brain. So people have extra movement if they have Parkinson's because those receptors for dopamine are damaged. They don't bind dopamine, so there's extra movement. And that's one of the classic symptoms. It starts with a tremor of the arms, and then it covers the whole body. Prozac and Zoloft. So Prozac is that fluoxetine? No, is that fluoxetine? And Zoloft is the generic, what is it? Sertraline, thank you. So those are very, very common antidepressant, anti-anxiety medicines, and they block the reuptake of this neurotransmitter. So your brain releases it, and it hangs out in the synaptic cleft to become available to help stimulate the brain. What is it? Serotonin, serotonin. You might see on like different drug labels, they talk about SSRIs, selective serotonin reuptake inhibitors. So that's what Zoloft and Prozac are, is they prevent the reuptake of serotonin back into the axon terminals of where they're released. It keeps them out there longer. So what does that mean then when someone's been on these medicines for a really long time and they decide, you know what, I'm going to stop taking these today. Cold turkey. What? Yeah, for one, they feel really sick because the body is used to these medicines and then you just take it away. So dizziness, nausea, vomiting, confusion, just horrible. So people need to ease off of these medicines. Oh. Is it locked? Oh. Sorry, I didn't see you sneak out. So, so people need to ease off of these medicines, and they need to ease into them. Sometimes it takes 6 weeks for these medicines really to get to peak levels in the blood and really be doing their job. And do you think some people become impatient when they go to the doctor and have these medicines? Yeah, they become very impatient, say, it's not working, I'm not taking it. So they stop taking it. Or there's side effects. They feel kind of nauseous. Maybe there's some weight loss or weight gain, and they feel really tired. Maybe they get a little headache or just feel off. So they stop taking it before it's even had a chance to kick in and before the body has adjusted to it. So it's really important when people need these medicines to give it time to kick in and to not stop them abruptly. And to not be afraid to take these medicines because it's not a sign of failure. If someone said, you've got, what's an example? Someone has acne and they take a very powerful drug called Accutane to control their acne. They'll do that before they'll take a medicine to control mood and make them productive members of society. And it's really sad because our brain is an organ like any other organ. If an organ isn't functioning well, why can't we use these wonderful medicines to help it function again? Right, and at its peak performance. So we might as well, accept the brain as another organ like anything else and be okay with these different medicines. But then on the flip side of that, if a person is living a lifestyle that promotes depression or anxiety because they're in bad relationships or they're just, living a lifestyle that isn't good for mental health, then we don't take medicines and then keep making bad choices either, right? What we do is we take these medicines to help us cope. If we're in a bad situation, you go to the doctor, you get on these medicines, and the medicines can hopefully clear a person's mind so they can cope and make good choices. And then the goal is to ease off the medicines if it's something that is situational. because people can get into a really bad state. Divorce is a classic one. Divorce is one, or going to school is another one, right? Anxiety levels can get really high to the point where you're not doing well, you're not making good choices, you're up all night, you're not getting good sleep, which causes more anxiety. Sometimes going on these medicines to kind of settle the nervous system down, help you cope, and then ease off the medicines as you adjust to school or a divorce. But some people have chronically low hormone secretion, neurotransmitter secretion, and they need these medicines throughout their whole lives just to maintain those neurotransmitters and health. So then you have to look at your family. Do I have a history of alcoholism, bad addictive behaviors in my family, people that committed suicide? Is it a family history? If there's a family history, then you got to say, the cards are not in my favor. That's probably why I'm not feeling well. I'm going to take these medicines lifelong. Really pay attention to my mental health. And sometimes these medicines stop working. They don't work as well. The brain adjusts. Then you got to switch to a new medicine, or you have to switch to an additional medicine, or up the medicine. But you got to keep talking about your mental health and not be afraid, because suicide has become like an epidemic in the last, 10 years, I would say. When I was a young person, I didn't know anybody who committed suicide. Now I know a couple of people. And people that just rocked your world, like, what the heck? They committed suicide? They were just totally normal, friendly, funny people, and they just checked out. So the responsibility is not always on everybody around them, because everybody around them, if you look at a lot of people, they had very loving, supportive people around them, but they, as an individual, made that choice to check out. And we have to empower the individual. It's not everybody else's responsibility. We, as our own people in charge of our bodies and brains, need to take charge of ourselves and say, I'm going to work on this. This is going to be a lifelong battle. I'm going to talk to the people I need to talk to when I need to, and keep going, right? Because you get one life, and that's it. And once it's done, it's done. So we have to keep trying, support each other, but also it's up to the individual to make that choice to stay, right? And these medicines can help, and sometimes they need to be adjusted. Okay, moving on. Nerve cells that are deprived of oxygen release excess amounts of this, destroying surrounding neurons. So what would cause nerve cells in the brain to be deprived of oxygen? What's a number one reason? What would cause nerve cells to be deprived of oxygen? What? Okay, constricting. But what's a more common cause that people end up in the ER? We're talking about neurons. So neurons are deprived of oxygen. Like the brain is deprived of oxygen in what major condition that happens all the time? What? Stroke. Yes, stroke. So if someone has a stroke, those neurons are deprived of oxygen, and it causes a dumping of this neurotransmitter, and that is glutamate. Glutamate is released in excess amounts, and that damages the neurons. Excess glutamate kills neurons. So that's why the brain dies. If we don't get people in when they're having a stroke and reverse that, it just kills, because of the glutamate, it's like a gasoline being poured all over the brain, and it's just dying as that process continues. So we need to reverse the clot and restore oxygen to the brain. And there's medicines we can give people within 2 hours of stroke that can, in some cases, have completely reversed the effects of stroke. But we got to get people in right away so they can get that medicine. And it's not driving them to the hospital, it's calling the ambulance, because the ambulance sometimes has this on the ambulance to give patients. So get the ambulance to that house and get them treated, and then we can save brain. Benzodiazepines, Ativan, Valium, Xanax. These are something that we don't like to prescribe a lot of. These are addicting. They really work well, though. They're good for short-acting anxiety relief. People that have panic attacks that are like here and there, they can take this medicine and it just helps them cope and relax and settle down. It doesn't last very long, but it's very effective. Like I said, those other medicines like Prozac and Zoloft take 6 weeks. Well, when you're in a panic attack and can't leave the house, or you're on the floor at work, they're definitely not going to give you one of those other medicines. You need something short acting, and these are really good for that. We give this for people that are having a lot of pain too and need to relax, like if they've had major orthopedic surgery. These are good medicines for that. So benzos, have you heard of benzos before? Yeah. We don't like to prescribe these for long term. Like I said, just here and there. In the hospital we give them. It's not something people should be taking. If they're taking it every day, every 4 hours, then they need a better drug, because that's not something we should be taking. So anyway, so they enhance the inhibitory effects of this neurotransmitter. I have to look myself, I forgot. And by the way, these are on page 421 and 422 of your textbook. Oh, where are they? Caffeine. Oh, adenosine was caffeine, sorry. Where is that? Did you find it? Oh, yeah. Yep, thank you. Gaba. Oh, I've already put there, we use to reduce the symptoms of alcohol withdrawal. Number 9 is Gaba, and the caffeine was adenosine. And adenosine, when we give that by IV, we give that to people that have really high heart rates, and it actually stops and resets the heart. It's kind of a scary medicine to give. I've never had to give it. Other people on our floor have, and it stops the heart briefly and then resets it. So it's definitely an inhibitory neurotransmitter. And lastly, this neurotransmitter inhibits the pain and discomfort during long runs, resulting in runner's high. Endorphins, yep, endorphins. Laughter releases endorphins as well. People have a good kind of feeling after, a big laugh. They talk about the importance of, being with friends or, just laughing. It does a lot for that. And smiling also releases endorphins naturally, even if it starts out as a fake smile. So they recommend people that have a little trouble with depression to work on smiling more. And when you smile, it causes another person to smile. It's kind of a human interaction, cause and effect thing. Try it with your patients sometimes. Just come in with a big smile, and you'll see them kind of smirk. Unless they're really flat and depressed, but in most cases, you'll get a smile back. So if you're feeling kind of glum because it's February blahs, work on smiling more today and see if it makes a difference. Okay. So that is that. I'm not going to test you on these, okay? So this was your test. You have that. That's your information. It's just important, I think, that we are aware of these things. What? Yeah, sure. Let's take a break. So we're going to continue on then, talking about just some more structural pieces of the nervous system. So this is a cross-section of the spinal cord. Remember, we have 31 pairs of spinal nerves coming into the spinal cord, and we have 12 pairs of cranial nerves coming into the brain. So when we look at spinal nerves, all spinal nerves carry sensory information coming in, and that's through the dorsal root of the spinal nerve, which is here. And then the information going out from the spinal cord to the muscles and organs is through the ventral root. So ventral root is motor information, outgoing. Dorsal root is incoming sensory information. So if I have damage to a spinal nerve and I damage just the ventral root, am I going to have numbness or paralysis? Or both? Just the ventral root was damaged. Paralysis, because that's the movement, that's the motor response. I'm going to have paralysis. If I have just the dorsal root is damaged, I'm going to have numbness, no sensation coming in, right? So if I have tingling, that means there's some damage, but I'm getting some information through. So tingling is an early sign of damage that will lead to numbness if people don't take care of their feet or what's causing the tingling, right? Or if you're sitting on your foot at home on the couch or sleeping on your arm, right? You know those sensations. So we look at the spinal cord then. The spinal cord has white matter around the edges, and that's myelinated axons. So we call those tracks. They're bundled. Myelinated axons are bundled into little pathways, highways, carrying specific information called tracks. So bundles of myelinated axons in the central nervous system we call a tract. Outside the central nervous system, we call it a nerve. So white matter is simply myelinated axons. So white matter is myelinated axons. And if they're in the central nervous system, we call them tracts. So that's the central nervous system. And myelinated axons outside the central nervous system, we call a nerve. That's in the peripheral nervous system, or PNS. So myelinated axons, tract or nerve, depending where it's located. So if we look at gray matter is not myelinated. It's the cell bodies and the dendrites of our neurons that are carrying information. Cell bodies and dendrites. So those are clustered into horns. So if I look at these horns, remember we looked at this in general A&P? So these are cell bodies and dendrites. So I can see that this is an axon. Here's a cell body in the middle. This is a unipolar neuron, which sensory neurons that are bringing information from the periphery, like sound and light and all that, most of those are unipolar neurons bringing information in. So the cell body is actually in the middle of the neuron. So here's the axon. Here's the modified pathway to the cell body, the dendrite. So it's the cell body's in the middle here of this neuron. So at the end here are my modified sensory receptors, carrying information in cell body, and then axon going into this horn. So this is sensory information. So when we look at the horns then, the dorsal horn carries sensory information, and the ventral horn in the front here, this butterfly structure, this is motor information going out. It contains cell bodies, dendrites of motor neurons. So they're not myelinated, so they have a darker appearance. That's why we call them gray matter, because we're looking at tissue that doesn't have that fatty white myelin coating. So the dorsal horn and the ventral horn, and then the lateral horn we see only in the thoracic and lumbar regions of the spinal cord. Those contain sympathetic neurons, but we're not going to talk about the lateral horn. That's part of the autonomic nervous system. I want you to just know the dorsal and ventral. That's most important. So this is sensory, this is motor.
So you can tell. I just sort of the sensory one has a little, or the dorsal.
It has the ganglion.
Like a lump.
Yep, and that's because of the special sensory neurons. There's different types of neurons, and this is in your textbook. Let's see, it's right in the beginning. On page 397. I'm going to see if I can find a picture online so I can keep my video going. Types of neurons. Here we go. So these are the 3 types of neurons. This is the most common neuron that we talk about. It's the most numerous in the nervous system, is this multipolar neuron. But this is the sensory neuron. So this is what runs from your sensory receptor. So here's my sensory receptor for light, smell, touch, temperature, taste, whatever. Bringing information in. This is my dorsal neuron, my sensory neuron coming through the dorsal root, and there's that cell body in the middle of the neuron, which is different, right? And then it comes into the spinal cord. So this is sensory neurons always have the cell body in the middle, and that's why we always see that ganglion, that swelling. So a ganglion is a collection of cell bodies outside the central nervous system, and a collection of cell bodies inside the central nervous system we call what? What did we call these things here, this butterfly? Each wing of the butterfly we called a tract is out here. Remember? A horn. Yep, a horn. So all of these, horn or ganglia, it's missing the L, add the L there. These are all cell bodies and dendrites. Okay, so cell bodies and dendrites are horns and ganglia. And then tracts and nerves are myelinated axons. So tracts and nerves are myelinated axons. So this would be the nerve, right? Out here is myelinated. This is the ganglion. This is a horn. These are myelinated axons running up through the spinal cord. But either way around, other way around. See, this is the spinal cord, right? This is the central nervous system. These are horns of the butterfly. So these are cell bodies and dendrites in the central nervous system, in the spinal cord. And these are cell bodies in the peripheral nervous system, in the nerves, right? And again, these are axons, so we call these nerves, and we call these axons clustered here. What do we call these out here? Let's just refresh. So what do I call this out here? What are these things here, these 4 different colored structures? What are those? What part of the cell body are they? Or what part of the neuron are they? Your choice is dendrite, cell body, or axons. What are these right here? These are axons, because they are the long part of the neuron, right? Dendrites are the receiving part of a neuron. So these are all axons. How about here? What are these? What part of the neuron are these? Axons. So these are all myelinated axons, so therefore we call myelinated axons outside the spinal cord, we call them nerves. Right? Myelinated axons are nerves, and this is something that you looked at in general A&P in lab. You had a cross-section you looked at in a microscope of myelinated axons. So these are all myelinated axons are called nerves. Then when those neurons, the next neuron in series comes in and goes up the spinal cord, it travels here, these myelinated axons. And what do we call myelinated axons that are running up the spinal cord? Tracts. Okay. And then the cell bodies that are connected to those axons are clustered into these little areas, which are called horns, because they're inside the central nervous system, right? Horns are inside the central nervous system. We're in the spinal cord. If we're outside the central nervous system and I see cell bodies only here, because we have these special sensory neurons only on the dorsal side of a spinal nerve, what do we call these swellings? It's labeled right here. Ganglion, right? Yeah. So use these pictures to study, okay? Because it's labeled right here. Horn, ganglion. Maybe highlight that if it helps you. I don't know if it'll let me. Yeah, there we go. right? So ganglion, horn. Really important you know this because we're going to go to a more advanced topic now, talking about these pathways. So all these colored structures here are tracks. Can you see? Tract, tract. So there's ascending tracks and descending tracks. So ascending tracks are bringing what type of information? If it's incoming information heading to the brain, sensory. Yep, sensory or afferent. And then descending tracks are bringing what type of information? Motor or movement, right? When you think of the word motor, think movement. So we're going to respond in some way via the descending tracks. And notice where they're located. Aren't they located in the white matter of the spinal cord? The ascending tracks are highlighted blue and the descending are highlighted red, but they're outside that horn, right? They're outside the butterfly. They're in that white area. So this is white matter, even though it's colored red and blue for our, being able to see them. So when we look at the ascending pathways, there's 3 neurons in a series carrying information in. So let's look at those 3 neurons. I'm just going to bump over here. So we're bringing information into the spinal cord. So we have one here. This one is in the muscle. This is a spinocerebellar. And another one is this dorsal column. So it starts out with a sensory receptor. It comes in and goes up the spinal cord all the way to where? The medulla. Then it crosses over to the next neuron. So the first neuron starts out here and goes all the way up the spinal cord to the medulla, so the brain stem. Then it crosses over to the thalamus, and then the third neuron kicks over and goes to the somatosensory cortex, which is our post-central gyrus, if you remember that from general A&P. So this gives us sensation of, oh, something is touching my foot, or something is touching my arm, or I'm having pain in my elbow, or I'm having pain in my back. We have these sensory pathways telling us different pieces of information. So what I want you to know is the name of the pathway. So the spinal thalamic tracts carry information about pain, temperature, and coarse touch. And there's 3 neurons in series, and they cross over. So if my right hand receives information about pain, temperature, or touch, the left side of my brain is what receives the impulse, because notice this neuron crosses over right when it comes in. To cross over means to decussate. You'll see the word decussate in there. Just means to cross over to the other side. So anyway, why do we care, right? Why are we looking at this? This is really, you wonder, how does this apply? If someone has pain, think of it like cars on a highway. Let's say pain is a semi, and then you have temperature is a school bus, and coarse touch is a motorcycle. And all 3 are on the highway emitting their engine noise at the same time. Does the motorcycle and the bus kind of crowd out the sound of the semi a little bit? If all 3 are traveling at the same time past your house, wouldn't you kind of hear them all together? Where if just the semi was traveling by your house, you'd say, oh, yeah, that's a semi. So sometimes when we add more sensory inputs in a tract that carries them all together, and that's this tract, the lateral spinal thalamic tract, carries all 3 of those together. If a person's having a lot of pain, giving them ice or heat or massaging helps reduce their perception of that pain, doesn't it? It doesn't fix the source of the pain, but it confuses the sensation because the information is going to the same place. And that's why when we're out of ideas, we've given someone the maximum amount of oxycodone, they've hit their PCA pump as much as they can, we're going to offer them some other options. And sometimes a change of position, or what do you do when you bump your elbow and hit your funny bone? Yeah, you yell, but don't you rub it right away? You've learned already that massage, coarse touch, helps lessen the perception of that pain. It doesn't make the pain go away. It just confuses your sensory pathway to feel the touch more than the pain. So it's really important that we try these things. How about a headache? How many times have you asked someone to rub your neck or shoulders if you have a headache? And it's like, wow, it went away. And then within about 30 seconds, it comes back, right? Unless it's a tight muscle kind of headache pain. But it's really important to remember these things. They share the same pathway. There's one more I wanted to talk about. The dorsal column. So the dorsal column, these carry information for discriminative touch and vibration. Remember I told you in lab that my husband cannot feel vibration on his skin? That's because he probably has damage to the dorsal columns. So this pathway, this is an ascending pathway. If it's damaged, you can't feel two-point discrimination, you can't feel fine touch, and you can't feel vibration. So this is really fine sensation touch, which is in the dorsal pathways. So there's two types of dorsal pathways. There's the fasciculus cuneatus and the fasciculus gracilis. It just depends where it's coming from. If it's coming from the arms and the hands, that's the fasciculus cuneatus, and the gracilis is from the foot. So it's just upper body, lower body ascending pathways, and again, it's discriminative touch. Notice here they're tickling with a feather, so it's very fine touch. And we're assessing dermatomes, right? Dermatomes are where the sensory receptors start for these pathways. So there's two types. There's the spinal thalamic that we care about in nursing with the pain issue, right? And then there's the dorsal that brings fine touch and vibration information into the spinal cord. A lot of slides taken up on that pathway. And then the descending pathway is only two neurons in a series. You have the upper motor neuron and the lower motor neuron. So these start in the cortex, in the precentral gyrus, and they end in the skeletal muscles. So this is all about movement, the descending pathways. So here's the upper motor neuron, starts in the cortex, comes down the tracts via the descending pathways, crosses over, and innervates that skeletal muscle, the lower motor neuron. So if a person has nerve damage and they have paralysis to a leg, was it the upper or lower motor neuron that was damaged? Where is the lower motor neuron located? In the nerve, right? So nerve damage is going to damage lower motor neuron. If a person has a stroke, which neuron is damaged? Upper or lower? The upper, because they've damaged this neuron here due to lack of blood supply here that has affected the primary motor cortex. So that's where it starts. So the impulse in the descending tract starts in the motor cortex and ends with the skeletal muscle, right? The ascending pathways start with the sensory receptor and end in the somatosensory cortex. So if we go back here, that's where they end. That's the end of the line for this tract. And it started with a receptor, right? Here it was here it was a proprioceptor. The muscle spindle is what's in our muscles. When you hit your knee with the reflex hammer, the receptor is the muscle spindle. And when we touch the foot or the hand, that's a sensory receptor. These receptors, yeah, that's the beginning. That's where they start. For the ascending pathways, right? So it starts there, and it ends here in the somatosensory cortex. And how many neurons are there? 3. And then in the descending pathways, we said it starts here in the motor cortex with the upper motor neuron. right? Upper motor neuron, and it ends down here, the lower motor neuron. Whoop. At a muscle cell, skeletal muscle, because it's all about movement, right? The descending pathways are all about movement. So we have direct and indirect pathways. The indirect is about balance and posture, coarse movements, head, neck, and eye movements. But I'm not going to hold you accountable for the different types of pathways. But there is a difference between the two descending pathways. The direct is about fast, fine, skilled movements. So some people are good at this, right? Some people have fast, fine, skilled movements. They're your athletes, right? Your musicians. They're really good at fine, skilled, fast movements. Other people are not as good at that. They're just, their nervous system doesn't work that way. And we do know that the more we practice a skill, the more we refine these descending pathways, and the impulse can travel faster. So when someone's picking up a new skill, like trying to learn the piano, you know, they clunk through the keys, and then they get frustrated and they quit, right? But people that really like piano continue to try because they like it, and then they get faster, and they get faster, then they get better, and that's more motivating, and they keep trying, and they keep trying. The same thing with nursing. When you first start out with nursing and you're doing your first IV push or your first sub-Q injection, it feels really awkward and you feel like you're this terrible nurse. Well, and then you have a preceptor that's following you and that's showing you how to do it, and they're so fast at it. That is not a reflection of who's the better nurse. It's just who's done it more, right? It's like anything. If you do it a bunch of times, like changing a baby's diaper, if you've had a lot of kids, you can do that with your eyes closed practically, right? But if it's your first time, it's awkward, and right? So don't be hard on yourself when you start out in your careers. When things feel a little awkward, it'll get better. I guarantee it. The more you do it, the better you get. That's a challenge with me being an on-call nurse. I'm not fast when it comes to like hooking up multiple IVs and getting the pump right and getting everything correct. So I do as much as I can in the med room so the patients and the family's not just sitting there watching me struggle with the pump and the tubing, because it takes a while to get that sorted out. So I try to do most of it in private where I can concentrate and take my time, and then I bring it all into the patient room. So you might benefit from that as well. Okay, so that's the descending pathways. So when someone has an injury, there's two types of paralysis that can happen. Flaccid paralysis means there's no stimulus to that muscle. And that means we have damage to the ventral root or the ventral horn, so there's no stimulus to that muscle because the lower motor neuron is damaged. But we can have spastic paralysis if the lower motor neuron is okay, but the upper motor neuron is damaged. We see that in cerebral palsy. Cerebral palsy is a condition in which the motor cortex has been damaged. Oftentimes it's a result of lack of oxygen, either during childbirth or after childbirth. Shaken baby syndrome has caused cerebral palsy. I worked on the PEDS unit for a while, and we had young toddlers that had cerebral palsy. One was the result of a child at a babysitter's house, and the babysitter got frustrated and smothered the crying baby with a pillow, and then realized what she had done, and then called 911, and they revived the baby. But because she was deprived of oxygen for that time, she ended up with cerebral palsy. So beautiful, healthy baby smothered by a caregiver. So I can't emphasize enough how to do your research and never leave your child. If there's ever a question in your mind about the safety of a child care environment you've chosen for your child, do not take them there. I mean, there has been times that one time when I taught in Alaska High School, I had my son on my hip with me as I was teaching, waiting for my mom to come and pick him up because I did not feel safe leaving him at his daycare place. And I just said, I brought him, set him down, saw what was going on in the environment, and picked him right back up, and I said, we're not going to be coming back. And I took him to work with me. And
Mm-hmm.
horrible, horrible, horrible. Yeah, foster care is meant to do good things, but there's many people that are in it for the money, unfortunately, and yeah, it's scary, very sad. So these two types of paralysis, again, if just the upper motor neuron is damaged, the lower motor neuron, remember we have reflex activity we talked about in lab? This impulse comes in, there's an interneuron, it jumps out and goes right back out and causes contraction. So what happens is reflex activity continues uncontrolled because the upper motor neuron is not inhibiting it at all, and you have constant muscle contraction. So these people have very stiff joints, it's hard to move them, and their muscles are just constantly contracted. So that's what spastic paralysis is. Oops, and it's oh my gosh, where did I go with my PowerPoint? Again, you're not, I'll tell you a little bit here in a minute. Just hang with me here. So, we lose sensation. What is that? That is what tracts are damaged if we have sensory loss or paresthesia. What tracts are damaged? Descending or ascending? Ascending. Ascending tracts are damaged. If we have paralysis, what tracts are damaged? Descending. Descending. But we can also have nerve damage. We can have great tracts, but the nerves are damaged. So what nerve would be damaged if we have sensory loss? Dorsal root or ventral root portion? Yeah, for sensory loss, which part of the nerve carries sensory information? Dorsal, yep. And the ventral is what would cause loss of motor function if we have damage to the ventral root of a spinal cord. So then paraplegia, quadriplegia depends where the damage occurred. So if I totally cut it in half, break your neck and sever the spinal cord, you're going to lose sensory and motor, right? Going anywhere below where the damage occurred. So paraplegia is when we have damage to the spinal cord at T1 and L1. So you're talking about, mid-back and down is going to cause just paralysis and numbness in the legs. And then if it's in the cervical region at all, it's loss of function from the neck down, including breathing.